My name is Alexa. I am a third-year medical student at Torocom in New York, and today we're going to be talking about COPD. So just to start off, if I'm going too fast or if you have a question, just stop me. This is super, I'm super cool with you guys just interrupting and saying if you have questions or if I'm going too fast. So don't worry about that. All right, so a little meme to get started off. COPD is everywhere. So you'll see when you get to your rotations in a couple of years that almost every day, you come in contact with people with COPD exacerbation in the hospital. So this is how we're going to break it down today. So first, we're talking about a case. I'll give you a good HPI. We're going to go through physical exam notes, and we'll talk about differential diagnoses, which are super important. And they're kind of a good thing to keep in mind the whole time from when you start looking at the patient's chart up until, when you see them and what you're trying to figure out what to do next. We'll move to assessment and plan. So this is when we talk about, okay, so these are the findings. Let's figure out the actual diagnoses that they have. And then what's the plan? What are we going to order for them? What are we going to do? What's their course? And then finally, there's a short lesson on the pathology of COPD. So I'll explain kind of a little bit of physio. And we'll get into that. So what's your role? Your role is to actively participate. Like I said, just jump in, turn your mic on, say something if you need to. I'm totally cool with that. And then also you're going to fill out the SOAP note throughout the presentation. So a SOAP note is what you fill out, which I'm sure you guys know this from the other presentations you've seen here. It's what you fill out, every physician will do it. It's your note after a kind of meeting with a patient. And if you were a scribe or if you are a scribe, you definitely know what a SOAP note is. And then after the presentation, you'll have a quiz that you can complete. And I believe you need an 80% or better on it to get a little certification. So yeah, that's what we're going to do today. All right. So everyone should have this SOAP note up in this Google form. And then as we go through, we can fill it out. And if you have questions, obviously jump in. We can talk about each part. I'm going to skip this for today just because I don't really know how to use it. And I feel like it kind of takes a little bit of time away. So we'll skip on the map, but I'm from New York. So New York is way up here. Okay. Hold on, freezing up. Okay, there we go. All right, so this is the case, right? So this is where we're going to find out, this is when you walk into a patient's room and you're talking to them, this is what you're going to get from them, right? A 67-year-old male presents to the ED with a chief complaint of, I have another chest infection. The patient has a past medical history of COPD, hypertension, and hyperlipidemia. Family history includes diabetes mellitus in his father and coronary artery disease in his brother. The patient reports that he has been having worsening shortness of breath, cough, and a funny feeling in his chest. So a lot of times when we're taking an HPI, you like to use quotes, especially when patient kind of describes something on their own, right? Because this is the patient's own words. So we want to keep that true to what they said. So we'll put it in quotations, right? So this guy's saying he has a funny feeling in his chest over the past week. Patient thinks he has gotten sick from his grandkids who had a cold last week. The patient is a current smoker with a 30-year PAC history, does not drink alcohol, and does not use recreational drugs. Patient endorses dyspnea, productive cough, and chest tightness. Patient denies discomfort with positional change, edema, diaphoresis, abdominal pain, nausea, vomiting, myalgias, fevers, weight loss, night sweats, congestion, rhinorrhea, headaches, changes in discomfort related to eating. Excuse me. Patient's medications include eplerenone, Lipitor, and Duanep. Compliance is unknown. So a lot of times when we go to take a history and someone's taking, a laundry list of medications, you ask them, okay, when do you take them? How often do you take them? And, are you compliant? Do you take them every single day? Do you ever skip days? So right now, this patient's compliance is unknown. The patient states that he doesn't need all these medications. So I've kind of highlighted some important things that we want to keep in mind here. So number one, the age of the patient. When you are looking at certain diseases, especially when it comes to respiratory things, a good way to kind of start to get differentials in mind is using age of somebody, right? So this guy is older. He's in his 60s, his late 60s. Past medical history is also super important. So we know he has a history of COPD, hypertension, hyperlipidemia. And so some of these things are certain risk factors for certain diagnoses. And then we can move on to, he's had a funny feeling in his chest over the past week. So time frame, right? So this is saying with, the past week, which is, quite in a long time for chest discomfort. And then he thinks he's gotten sick. So we know that his grandkids had a cold last week. So that can cue us in. Okay, we're starting to kind of form differentials at this point, right? Are also 30-year pack history and compliance is unknown for medications. All right. All right, so different questions to consider. So number one, is the patient a good historian? So someone unmute quick and say, like, do you think he was a good historian? Like, did he have a good story? Do you think he was like with it enough and his mental status was good and was giving a good picture? Anybody? Yes, no? All right, I'm going to go.
I think so.
Okay, perfect. Yeah, so what's your name? Who was that?
Marin.
Marin, nice to see you again. Okay, so yes, I agree with Marin. I think he was a good historian. He seemed like he had a cohesive story. He could give you details. And you know, like he didn't have this ultra mental status kind of appearance. So next question we would think about is what aspects of the history stick out to you? So we're going to like kind of skip. I won't make you answer this one because we kind of highlighted them before. So the things that were highlighted in blue are things that would stick out to me. So age, his past medical history, what the patient thinks they have or where they think they got whatever they have from. And then also like his alcohol, drug, smoking history is also super important. And then the last thing I think on that list was his drug compliance or his medication compliance at home, because, you know, if someone says that, you know, they don't think they're super compliant with, or they don't think they need the medications, we start thinking, okay, well, like, what do these medications do for the person? Are they having some sort of kind of secondary thing to not taking their medications? And then third, what are some differential diagnoses? So can someone give me one thing you'd put on your differential list? It can be literally the most obvious thing if you saw the title page of this.
Either asthma or COPD.
Perfect. So asthma, COPD are good ones. And if we look at the next slide, I think I've listed a bunch out. Yep. So when you're looking at differentials, when you're trying to form a list, it's nice. I like to go by like system. It kind of helps me categorize things and keep things into like boxes and kind of separate. And from there, we can do different tests and different lab values and stuff to narrow them down. So starting with the cardiovascular system, we could think of NSTEMI or pericarditis, right? So NSTEMI, does anyone know what that is? What an NSTEMI is? So an NSTEMI is going to be a non-ST elevation myocardial infarction. That's what the letters stand for. And so what that's saying is this person's having a heart attack, right? A myocardial infarction, but there's no ST changes on the EKG. There's no, so usually in a STEMI, right, a ST elevation, you'd see this certain segment on the EKG is like elevated. So with an NSTEMI, it's not elevated, but they're still having ischemia to the heart tissue. Oh, sorry, guys. Hold on, there we go. The next thing on this list would be pericarditis. Oh, Lord. Oh, hang on, I'm calling 911 on my phone, so that's great. All right, so next is pericarditis. This would be like inflammation of the tissue around the heart. And the fact that we're having these two on our differential was kind of leading us because we had that chest discomfort, right? So he was thinking chest discomfort. Anytime someone's in the ED saying their chest hurts, chest tightness, chest pain, we automatically want to put these on our differential because we don't want to miss a heart attack, right? Respiratory is next, right? So someone had said asthma and COPD exacerbation. Those are two perfectly great differentials. And we obviously know we're talking about COPD today, right? So we're going to put that on there. Another one would be pulmonary edema. So he said he was having cough, he was having chest, tightness. Pulmonary edema can be caused by a bunch of different things, but most commonly it's left heart failure. So we know we have a right and a left part of our heart. And so the right heart goes from right heart to your lungs to your left heart, right? And then out to the body. So if we have left heart failure and our heart is not able to pump that blood out to the body, it could be backing up into like the left atrium and then up into the lungs, causing this pulmonary edema and essentially like a nasty cough. The fourth thing would be lung cancer, right? Because he said he was coughing. Gastrointestinal, GERD. To be honest, one of the most common reasons people have like a chronic cough is GERD. And you probably wouldn't think about that, but it's true. And it can also cause some chest discomfort as people would describe it. So it feels like there's a burning substernally, like behind your sternal bone. And this could just be GERD, right? Infectious wise. So two things we could think about are an upper and a lower respiratory tract infection. So upper respiratory tract could be like a common cold, especially since he said he was in contact with his grandkids who had a cold the past week, and then a lower respiratory tract infection like pneumonia. And finally, musculoskeletal costochondritis. I have yet to see this in person. I think it's harder to diagnose because it's kind of almost like a diagnosis of exclusion. And that's basically when the costal margins of your ribs are inflamed. And so they cause some chest wall pain. And we'll see there's different ways to kind of figure out whether it's like cardiovascular chest pain versus respiratory versus GERD versus musculoskeletal. Does that make sense? Everyone good on that so far? All right. All right, so physical exam. So first thing we always want to do, and usually the nurses will do this before you even come in the room multiple times, are vitals, right? So his Tmax, which is the max temperature that he's had since he's been, in the ED so far when we saw him, is 98.4, which is afebrile, right? So he has no temperature. Heart rate was 104, BP was 189/92. Respiratory rate was 22, SpO2, which is the saturation of oxygen, is 89% on RA. What RA means room air, right? So you can either have like a nasal cannula or high flow oxygen or room air. So he's breathing at 89% on room air. Does anybody know what the normal SpO2 should be, or like what a healthy SpO2 should be on room air? So it should be 95 and up, right? Anything below that, you start thinking, okay, this person might not be getting as much oxygen as they need. The other alarming thing here would be the BP, right? So 189/92. So normal BP is, I think the guidelines now are less than 140/80. And so he's got high blood pressure right now. Heart rate is 104. Normal heart rate is 60/100. So that could be cueing us in that something's going on. His heart rate is elevated, his BP is elevated, and his O2 is pretty low. His respiratory rate is also on the high end, right? So usually it's 16/20. We're at 22 right now. Okay, so on physical exam, we see there's actually another, there we go. Okay, so this is our guy right here. This is our patient. And this is, a side view of him. And it may be hard to tell in this picture, but when you're in there looking at him, you see that his chest is kind of barreled out. So instead of being like a flat, sternum up here and flat chest, it looks like a barrel from the side. You also see fingers here on the bottom. Does anyone know what this is called when your fingers turn this color? Blue color, anyone know? This is called cyanosis, right? So that's another cue that, maybe this person's not getting enough oxygen if they're if their distal extremities are turning this bluish color. And then we'll take our stethoscope, we'll listen to lung sounds and heart sounds. So just turn your volume up as much as you can for a second so you could hear this. I think it's kind of low, but. All right, so that was his lung sounds and also the heart sounds. Oops. All right. So did anyone find anything funny with the lung sounds and heart sounds sound normal? Did they not? Anybody? You can give me the most absurd answer. I just would love to hear someone speak.
I couldn't hear it, but I presume that it would be something of like congestion. It'd be like a crackling or something hard to breathe.
Okay, that is a really good point. Is that if someone was congested, so say they had some like fluid overload, they would have crackles because the crackles are indicative of fluid in the lungs. This, however, I don't know if you guys can hear it. So basically on the lung sounds, we heard wheezing. We heard expiratory wheezing. So Matthew, what do you think expiratory wheezing would kind of cue us into? Like, what is this kind of pushing us towards in terms of differentials?
I guess wheezing would be that, like, I guess he's straining to breathe. I don't really have experience with pulmonary.
You're good. No, that's okay. We want to talk about it. So you're actually on the right track. So what it means is that there's some sort of like obstructive process going on. If he has, so when he breathes out, it makes this wheezing sound. It means that it's hard for him to get the air out of his lungs for some reason. On his heart, and that heart was definitely hard to hear. I know that. Normally we have an S1 and an S2 heart sound. So it's like, they usually say like lub dub or whatever the thing is they call it. However, this guy's heartbeat was super irregular. You would call it irregularly irregular, and we'll see later on, what the actual diagnosis name is that is. But it was super irregular. So he'd have like S1, S2, and then he'd have like very irregular spacing between those. So it sounded just very awkward. All right, lab values. So in this column right here on the left, you'll see what the patients are versus the normal range on the right. So the ones I highlighted in red are going to be the ones that were kind of off and, you know, abnormal. So we see his red blood cell count was 7.9, which is higher than normal. His hemoglobin was 8, which is a little lower. Hematocrit was 33, also low. So hemoglobin and hematocrit go kind of hand in hand. So if one's low, the other one can be low. Then we skip over to the second column, the second graph over here. His CO2 was 47. His creatinine was 1.93, so both of these are high. Glucose and A1C were 203 and 6.3 respectively, so those are both high as well. And then his troponin was 0.04. Does anyone know what troponin, where troponin comes from or what it's indicative of? So troponin is going to come from your heart. It actually comes from, depending on which troponin you're looking at, it comes from different muscles, but we like to use it to indicate heart strain. So maybe this could indicate that there's maybe some ischemia going on in the heart. All right, so after you get the blood drawn, you get the lab values, you also want to get an ABG. You want to see an arterial blood gas, which is like what is this guy's acid base, you know, status at this point? And especially because we know he's breathing, he's having trouble breathing. He's got the wheezes, he's got the low SpO2. You want to check and see, is he in some sort of acidosis alkalosis, right? So if we look, his pH 7.31, which is low. So when your pH is lower than normal, that's called an acid, it's acidotic. His PCO2 is 52, which is higher than normal. And his bicarb is 27, which is also higher than normal. So acid base can get kind of confusing. And you'll learn in every single year of med school and on like different acid base problems. And it goes into like this whole rabbit hole. It's great. But with these, we would call this a respiratory acidosis. So what that means is, so basically when you're breathing, you are breathing in oxygen and you're breathing out CO2. You can think of CO2 as like an acid. So your body is kind of breathing off that acid as you kind of respirate. This guy is having trouble breathing out, right? He's got some sort of obstructive process. So what's happening is he's retaining that acid, causing the pH of his blood to drop to the 7.31. That's why we also see the high CO2, because he's retaining that CO2. And then with the bicarb, what happens is when you're you know, can't get your CO2 out, your kidneys start to compensate by making more bicarbonate. And so that's why you see his bicarbonate raised up a little bit. You also get pulmonary function test, which is red in the bottom. And you figure out that his FEV1 over FVC is 60% and normal would be 80% and above. And with the FEV, that means forced expiratory volume in 1 second over the FVC, which is the functional vital capacity of the lung. So forced expiratory volume is going to be how much the person can push out, how much breath they can push out forcefully in 1 second over the amount of kind of air that's calculated to be in their lungs that's usable. So his is low. So that means if you look at, all right, so let's go back to like third grade fractions. If this number is low, that means that his FEV1 has to be lower than his FVC, right? So we know that he's having a real hard time pushing out that air because he's getting a really low number for his expiratory volume in 1 second. So next, after we got our lab values, we got our ABG, we want to look at a chest x-ray. Like I swear to God, anyone that comes in the ED gets a chest x-ray. Sometimes I wonder if they actually need it, but this guy definitely needs one. So on the left, we see a normal chest x-ray. We see nice rib shadows. We see a nice sized heart. Everything looks midline. I don't see any broken bones anywhere. And I see the vascular markings. So if you look kind of like right on either side of the heart here, you'll see these kind of white wispy things. Those are the vascular markings. We like to see those. And these look really nice and normal. The heart should be less than 2/3 of the diaphragm down here. So on the bottom, this white thing is gonna be your diaphragm. Here's your lungs, these black spaces. And the reason they're black is because they've got air in them, right? So air is gonna come up as this dark, color on here on x-ray. And then of course, in the middle, we have our spine going down the center and our heart right here. On the right, however, this is our patient's chest x-ray. So what do we see? I see tons of black in here, right? So I see a whole bunch of air in this lung and also this lung. So what would that tell us? If we're thinking he's got some obstructive kind of disorder, we said he's got respiratory acidosis where he's retaining CO2. Does that kind of follow along that he's kind of retaining air as well in his lungs and they're kind of hyperinflated at this point? Yeah, right. It would tell us that it's what's called air trapping. And another way to see is by looking at the apex up here. You can see that over here, it's got this nice kind of like dome shape, not really a dome shape, but like it has like an apex to the top, right? Over here, it's flatter and it's wider at the sides. So you can see like his lungs are super filled up and they're less pulmonary markings here because of the air is showing. And yeah, his heart actually looks like a pretty good size here too, so that's okay. Another thing is you can see the flattened diaphragm. So if you look at the diaphragm on the left, it's kind of domed up like a diaphragm should be. Like when you see it, so when you get to cadaver lab, you're gonna see like the diaphragm's like it literally comes up like this. However, this guy's is super flattened out, and that also kind of goes along with the whole hyperinflated lungs, because as your lungs inflate more, they push down on that diaphragm and it flattens. Another thing to also look at would be the rib shadows. So you can see the rib shadows really clearly on the normal chest x-ray, but here it's hard to see. But in COPD, the rib spaces in between each rib shadow should be wider because again, your lungs are kind of pushing up, super inflated, your chest is all barreled out. So those are some things to like to look for. All right, so next we would take an EKG. Everyone gets an EKG as well. And so on here, we see this funky baseline, right? So it looks super irregular. So when we talked about before, irregularly irregular. So we're talking about rate and we're talking about rhythm. So with the rate, we're going to be looking at the QRS complexes. So from one R to the other R would be like our heart rate, right? And with this, we see that, and it's easier to start when there's like a straight box on a line. So let's start with this one right here. It kind of hits a big box right there, right? So this one goes to one big box and two big box. So it's about 2 1/3. But then we go 1, 2 1/3, and we're not there, right? This one's even farther apart. So the heart rate is all kind of different. It's variable. So that was the rate. And then the rhythm would be kind of this line here. And I don't see a clear rhythm, right? I don't see a clear P wave. I don't see a clear ST segment. It's all over the place. So does anyone know what this is called when it's an irregular rhythm? This is called AFib, so atrial fibrillation. And you see this a lot in hospice. This is a very common one. So that's what this guy has, and that's why he had those weird extra funky heart sounds in that video. So right here, his ventricular rate is 105. So he has a elevated heart rate. So we can also call that tachycardic. And he also had a previous echo in his chart, and it was 60% ejection fraction. So an echo kind of measures different things like wall motion abnormalities. It can measure the ejection fraction, and the ejection fraction is just how much blood is being pumped out of the heart with each beat. Or the percent of blood's being pumped out. So his is 60, his is normal, that's fine. So we're not really worried too much about the functioning of his heart, and we're kind of thinking, okay, probably not as much heart failure right now because his ejection fraction is looking okay. All right, so I just jumped by a bunch. Here we go. Okay, so back to our differential. So now we got all of our information. We got the labs, we got the ABG, the PFTs, the imaging, we have his HPI. We can go through our differential and kind of cross out some things. So NSTEMI, we're going to cross that out because the EKG did not show any ST changes, right? Which would be an NSTEMI still, but the patient denies the chest pain that you're typically looking for. So you're typically looking for the substernal kind of crushing or tightened chest pain. And he had a very mild troponin increase. So I know before we said he had an elevated troponin. Instead of 0.03, it was 0.04. However, he wasn't, actually, you know what? I think it's supposed to say STEMI right there, so ignore me. No ST elevation because it's not STEMI. And then very mild troponin increase, because if he was having a STEMI, his tropes would be jumping a lot higher than just 0.01. You know what I mean? So we can kind of get that off the differential. As for pericarditis, so we said that was inflammation of the lining around the heart. This type of disease has chest pain as well, but it changes with position. So it's better when you're sitting up and leaning forward, and then it's worse when you're laying down. So he said the patient had said that there's no really position that changes his chest pain, and that, you know, it wasn't better sitting up or laying back or anything. So we can kind of cross them and off. Also, you'd also see diffuse ST changes with pericarditis, which the EKG did not show. Respiratory wise, so asthma. So like we talked about before, his age is 67. So usually asthma presents at a very young age, you know, in childhood or young adulthood. It's not typically diagnosed in an older person. There's also no past medical history of asthma that he had spoken about. We'll skip COPD exacerbation. So pulmonary edema, the chest x-ray did not show the pulmonary congestion that we would normally look for with edema. And also the echo, he had a normal EF. So we can kind of cross off like that left heart failure kind of differential. Lung cancer, there was no pulmonary nodules in the x-ray. He denied fevers, night sweats, and weight loss. So whenever you go see a patient and you go through HPI, I always make it a point to ask, like, fevers, night sweats, or weight loss. Do they have any of those things? Because those are what we call like B symptoms of cancer. And, if a patient has those, you definitely want to keep cancer higher up on your list. But since he had none of them, we're going to put it a little lower, right? Gastrointestinal, so GERD, he denies discomfort, changes in discomfort when eating. So someone that has GERD typically has, so it's an overproduction of acid, right? It's burning their esophagus. They have a lower tone of their lower esophageal junction or lower esophageal sphincter. So they're going to have the acid kind of coming up into their esophagus. And with this guy, he was fine after eating. Usually after eating or before eating, you'll have like more acid being made and more GERD symptoms. But this guy said no, so we're going to kind of keep that low on a differential. Infectious wise, so with infection, someone tell me one thing. If I said like I had an infection, what would be one symptom of mine that you would see on vitals?
Elevated white blood count.
Perfect. So that would be more, that would be lab values, but good point. And what about vitals? So what's something in the vitals?
High temperature.
High temperature, right? You'd have a temperature, right? A fever. This guy had no fever. So I'm kind of thinking, once I saw that, I'm like, all right, I'm not thinking, infection yet. Let's check his white blood cells. He had normal white blood cell count. So no, and that's called leukocytosis if it was high blood cells. So he had no leukocytosis. He had no, runny nose, which is rhinorrhea, no fevers. So probably not a cold. And then for pneumonia, he also had, you can have a typical pneumonia where you have like the high blood cell count and the fevers and stuff, or you can have an atypical, like a walking pneumonia, where sometimes people appear to be less sick than they actually are. So like you might think someone's okay, you get a chest x-ray and their chest x-ray is a mess. That's more of like an atypical, like a walking pneumonia. But his chest x-ray in terms of like pneumonia wise was fine. There was no consolidations. He also had no white blood cell count, right? So what we're pointing at right now is a COPD exacerbation. So that would go along with what we said. He has a history of COPD. He's not really compliant with his medications, and a couple other things talked about in the HPI. But does everyone see how like you kind of use a lot of what the patient says, a lot of their history goes in, like history is super important in trying to, number one, make a differential diagnosis list, and number two, kind of narrow it down. And then our lab values and imaging kind of focus in and help us a lot more. But we use different things from his HPI to kind of narrow this down and help us pick which one was the best. Does anyone have any questions about any of these and why we kind of crossed them off or put them lower on the list? No? Okay, good. All right, assessment and plan. So this is when we think, okay, what are his actual diagnoses, right? And what are we going to do for him? So and when you do these in your notes one day, you want to put the most pertinent, like the most kind of acute problems first and kind of go in like decreasing order of importance, right? So we'll start with acute on chronic COPD. So this means that he's got chronic COPD, right? He has COPD, he's diagnosed, but he's having an acute exacerbation of it right now. So he presented with worsening dyspnea, productive cough, chest tightness over the past week, past medical history of COPD, diagnosed in 2014, no medication compliance. We'll write his vitals, his FEV1 over FVC, persistent hypercapnia on ABG. So hypercapnia, hyper means high, right? A lot more high. And capnia means CO2. So he has a high CO2 on ABG, which is the arterial blood gas. Chest x-ray showed hyperinflation, decreased lung markings, widened intercostal spaces, flattened diaphragm. So all of this in this top half of this paragraph right here is kind of all the information that brought us to the diagnosis. So a lot of times what people will say is they'll do, the name up top of the diagnosis, and then they'll put like an etiology. So what caused it or what the person presented with that supports your diagnoses, and then all of his vitals, labs, and imaging that support that. Okay. Now we move into the plan part. So at this point, we started him on 2 liters of oxygen. So the nasal cannula, that little kind of plastic thing that goes in their nose and around their face, that's a nasal cannula. And we're putting him on 2 liters. We want to put parameters and help, the nurses understand what we want to get his O2 to. So we're going to say maintain O2 between 88 and 92%. And hold on to that thought for a second, because remember I said that good oxygen would be 95%. We're going to talk about that as we talk about pathology. Home O2 evaluation ordered. So that means that someone's going to come in, check out, see if he needs like a nasal cannula to bring home with him later when he's discharged. And now our medication. So he was started on Duanep, which is, we'll talk about it a little bit, but it's an inhaler. It's like kind of got 2 medications in it to help dilate his bronchioles. IV Solumedrol, which is a steroid, and then IV azithromycin. So this is kind of like a steroid and azithromycin and inhalers are kind of like the standard of COPD exacerbation. So with the inhalers, we want to bronchodilate. With the steroids, we want to decrease inflammation. And with the azithromycin, which is an antibiotic, we kind of want to keep infections at bay. And it's kind of like a standard therapy for COPD. Also, we educated the patient on condition and medication compliance. I think this is something that's overlooked a lot. And especially as like a future medical student, when you get to your 30 rotations, this is something like you can excel in. Like, yes, you might not be able to order medications for your patient or, do every procedure, but you can spend the time that you have because you have way more time to spend with them than the residents do. You can spend this time and educate them on, their condition COPD. What do we do for COPD? Talk about the, in layman terms, talk about the physiology of COPD so someone understands, and what each medication they do, or each medication they take is helping them. Like, how is it helping them? Because I think when you talk to people, I mean, you'll ask them, like, what medications are you taking? And they say like metformin, right? Everyone knows metformin's for diabetes. But there'll be other ones that they'll take and you'll be like, okay, what are you taking that for? And they'll be like, I don't know, they gave it to me. And it's like, sometimes I think to myself, like, if someone just understood what that medication was doing, maybe they'll be more apt to staying compliant with it and kind of helping their disease process. But off on a rant there. All right. So next problem would be atrial fibrillation with RVR. So AFib, like we talked about, that irregular heartbeat, with RVR, which is rapid ventricular response. That means that the patient is tachycardic on top of their AFib. The patient was asymptomatic, which is, a good sign. His CHA2DS2-VASc score and his HAS blood score are both 3. So in internal medicine, when you do like your regular hospitalist rotations, you'll see that sometimes they like to use these scores. CHA2DS2-VASc score is and you can get them. There's a really cool app. It's called Calc MD or something like that, but you can do them right on your phone. It's great. CHA2DS2-VASc is a score that you use to determine what a patient that has AFib, like what their kind of risk of having complications are, like a stroke or a clot or something. And the HAS blood score is so let me back up a minute. So with AFib, your atria they're beating way out of order, right? They're not in sync with your ventricles. So when your atria is beating like this, a lot of blood can get stuck and kind of pool in the atria. And what can happen is you can form, the blood coagulates, obviously, you can form a clot, it can shoot off, go to the brain, go to anywhere, you can get a stroke, right? So with people with AFib, our main thing is we want to get them on blood thinners, right? We want to anticoagulate them to prevent the risk of a stroke. So we use CHA2DS2-VASc score to determine what is their risk of stroke. And then second, we use the HAS blood score to determine what is their risk of a bleeding event while on their anticoagulants, right? So it's kind of like we have to find like a happy balance. EKG showed AFib with RVR. So it's just, again, supporting what we found. The patient was started on a cardizem drip. So GGT means drip. I know that's funny. And I wanted to put it in here because it took me forever to figure out what that meant, but it means drip. And a drip is just like, like an IV, but it's at a pace. Cardiology was consulted and AC recommendations appreciated. So something I learned is like, it's nice to, you want to consult the specialty after you've done everything that they want you to do to figure out what the issue is. They'll come in and give their expert opinion on like which anticoagulation to give, depending on the patient and their scores. So AC means anticoagulation. All right, next, AKI. So AKI stands for acute kidney injury. So if you remember back to his, the patient's labs, we saw his creatinine was 1.93. Creatinine is something that's cleared by the kidneys. So a rise in creatinine is telling us, okay, these kidneys aren't working as well. They're not filtering out the creatinine, which means it's building up and rising levels in the blood, right? So he has a past medical history of COPD, hypertension, hyperlipidemia, newly diagnosed with prediabetes. His A1C was 6.3. So these are all kind of risk factors for AKI. I mean, especially diabetes. I think AKI and diabetes go together like bread and butter. His creatinine again was 1.93. When you're talking about creatinine, it's very important for to talk about the baseline, right? So someone could have a baseline. Someone could have like poor kidney function for whatever reason, their whole, for a long time, and their baseline could be like a 2. But if their creatinine jumps from a 2 up to like 3.4, that's like, okay, that's like probably an AKI now, but they could have just chronic kidney disease with a higher, baseline. But he's jumped from 1.04 to 1.93. So that's definitely a good jump. We're going to call that an AKI. He started on gentle IV fluids, right? We want to hydrate. We want to get stuff moving through the kidney, and we're going to continue to monitor him for now. Sorry. All right, third or fourth, I think it's fourth, is going to be demand ischemia. It's also called an NSTEMI type 2. So what demand ischemia means is that there is something going on in the body where the body is stressed. The heart is now stressed because it's trying to pump all this blood out to the body. It's trying to keep the body oxygenated, and it's just like pumping so hard and so fast that it's just kind of becoming ischemic. He kind of has double whammy because he's, number one, has COPD, so he's getting less oxygen to his body, so his heart's going to pump faster to try to keep up with it. But he also has AFib, so his heart is kind of beating out of order, irregular, so it's causing stress on the heart, and it's decreasing the amount of oxygen the heart muscle is getting. Good to note, though, is the patient denies chest pain, palpitations, and diaphoresis. So these three things are kind of symptoms of an actual STEMI, and he doesn't have those. So that's why we're going towards not even NSTEMI, but more demand ischemia, which is an NSTEMI type 2. There's different types of NSTEMIs. EKG showed no evidence of ST changes, again, supporting what we said. His trope was 0.04, which goes along with demand ischemia, right? We said if it was an MI, like a STEMI, it would jump up. He'd probably be at, like much higher than 0.04. So we're going to continue to trend the trope. We want to make sure it doesn't go up any higher. We want it to kind of stay the same and then come back, down to the less than 0.03. Next, he's got a normocytic anemia. So his hemoglobin was 8, which is lower, it's a lower it's a decreased hemoglobin and hematocrit. His MCV was 91. So with the MCV, this is where we're getting this normocytic. So we know he's anemia. When you have decreased hemoglobin, it's called anemia. And then his mean corpuscular volume is this MCV, and that his is 91. So it should be between, I think it's about 85 and 100. So he's right in the middle. He's normocytic. That means his red blood cells are normal size. They're not large. They're not small. So we're thinking this is likely anemia of chronic disease. So this occurs in people with chronic diseases, right? And what happens is you have these alterations in iron usage in the body, and iron is really necessary for hemoglobin, right? It's part of that heme ring that everyone should know about, because I'm sure y'all taking biochem or have taken biochem. So what we want to do is we want to follow up with iron studies. So check his iron, check his TIBG. We're going to check his what else? Ferritin. We want to see what's going on to make sure that this is kind of supporting our normocytic anemia of chronic disease diagnosis. And finally, prediabetes. So he has a family history of insulin-dependent diabetes type 2. His glucose was 203 in admission. His A1C is 6.3. So no matter what the glucose is, like the finger prick glucose, we always want to check an A1C, because the A1C will show us their glucose levels and give us an indication about 8 weeks prior to today, right? Because A1C is glycosylated hemoglobin. So at 6.3, he's prediabetes. I believe 6.5 would end up being diabetes. So he's on the cusp. So what we did was we counseled him on diet and lifestyle modifications, because when someone's in prediabetes, you can slow the progression to diabetes, hopefully for a while, with changing your diet, exercising more, losing weight. All these things are really great to kind of slow that diabetes progression. All right, so quick path kind of lesson on COPD, the respiratory system, stuff like that. So on the left, we have a picture of our normal respiratory tract. So we have the trachea with the cartilage rings, breaks into the main bronchi, which break into terminal bronchi, and down to our alveoli, which are all the way at the bottom. So the alveoli are where we have the gas exchange occurring between oxygen and carbon dioxide. On the right is like a histology image of what our respiratory tract epithelium would look like. So epithelium, you can think of like, I don't know, like your skin, right? So you have linings that kind of cover all these cavities in our bodies. So this particular respiratory epithelium is super important because we've got two things. We've got goblet cells, which if you can see my cursor, they're like these big, they look like they're full of like jelly right here. And these cells secrete mucus. And then you also have cilia, which are these little hairs that stick up on top of the epithelium towards the lumen of the trachea. And these are like an elevator. So what happens is your goblet cells secrete all this mucus to kind of trap bacteria and stop it from kind of reaching down low into our lungs. And then the cilia beat back and forth, and they move that mucus up that has all the bacteria in it so that we can cough it up and cough it out. So it's like our body's little kind of immune way of keeping us healthy in the respiratory system. All right, so in terms of the alveoli, so the very end of our respiratory tract, we have these alveoli which help in gas exchange. So let's follow kind of the blood first. So we have blood from the body goes into the right atrium, it goes into the right ventricle, it goes into the lungs, right? And then it will kind of do gas exchange with these alveoli, with the capillaries that are right next to the alveoli. And then that now oxygenated blood goes to our left atrium, our left ventricle, and then back out to our body. So with COPD, right, this is kind of two diseases for the price one. You have chronic bronchitis and you also have emphysema. So those both fall into the category of COPD. It is caused by a couple of things. So number one, chronic smoking. Smoking is a big cause of COPD. It causes inflammation, right? So which will lead to the changes we'll see down here later. Also, CD8 T cells. These are the cytotoxic T cells. They arrive at the site of inflammation. They release cytokines, which are these kind of mediators, these proteins that do a whole bunch of different things. And in very simple terms, they amplify the inflammation. So you get this inflammation from smoking, and then all of a sudden your immune system's trying to like help you out, and it's just increasing that inflammation over and over again. So what does the body want to do when there is inflammation? It wants to protect itself from further injury, right? It tries to protect, it really tries to help us out. So what happens is this chronic remodeling. So this means that you'll have growth factor secretion. These growth factors help they cause fibrosis of the airways in order to kind of try to eliminate or decrease some of that inflammation and injury that's going on. This ends up narrowing our airways. So this can cause this chronic bronchitis part, right? Then you've got goblet cells we talked about have mucus, they can secrete mucus. They'll start proliferating and they'll be making tons and tons of mucus in order to try to get up that stuff that's in your throat and kind of protect you from any more of that smoking inflammation. This also can contribute to that chronic bronchitis, right? So that nasty cough that you'll hear a lot. Also, the chronic remodeling causes inhibition of protease inhibitors. So this is kind of like a negative, right? So it's protease inhibitors are going to be these proteins that kind of inhibit the breakdown of other proteins, right? We're going to inhibit that. That means we're going to have more protein breakdown. I know it sounds, you'll see like when you get to med school, it's like a bunch, you'll see this often. They'll be like a negative, like an inhibitor that inhibits an inhibitor. Like it's funny, but all right. So this basically means that there's loss of elastin in the lung, and this can cause your emphysema, right? So when you have loss of elastin, you have this like hyperinflation of the lung. You can't you're having issues breathing out. You can't really, there's no recoil left to the lungs. All right, everyone good? I know that's like a lot of nitty gritty information, but if you're not good, just stop me. All right, so here's kind of like a little picture. I love pictures. I love diagrams. My whole career for school has been drawing diagrams to help me figure stuff out. So on the left, we have a healthy alveolus, right? So a lot of CO2 comes in from the body, it goes out through the alveolus, and then we end up breathing it out. In the meantime, we're getting a lot of O2 in, and we're nice and oxygenated for the blood to now go to the body again. In COPD, we've got tons of mucus, which is this yellow blob here, right? Tons of mucus in the airways. We've got inflammation, which are these red bars. That's kind of narrowing our airways. So when we have mucus and inflammation, it makes it hard for us to breathe in and out, right? Especially out because our airway is kind of obstructed. On the other hand, if we see this alveolus here, this looks like a big bubble, right? It looks like a big floppy bubble compared to this nice round circular one here. So this is what happens when we lose our elastin in our alveoli. It kind of gets floppy and it won't kind of recoil. So instead, when you breathe in, it should come back and recoil when you breathe out. When you have loss of elastin in the lung with COPD or emphysema, you're going to have breathe in and it like doesn't want to come back in. So kind of air traps. So when our blood's coming through from the body and it has all this CO2 in it, it kind of gets trapped here. We can't push it. We're having two obstacles and we can't really push it out of our lungs. And we're also having issues getting oxygen in. So there's less oxygen in the blood going to the body. So, for diagnosis and evaluation. So we kind of finished up our little path lesson there. So common patient presentation, it should be worsening shortness of breath and a projective cough. That's kind of cueing you into COPD. Different things to keep in mind. So you want to take a really good history. You want to know what your patient's feeling. You want them to describe it to you. You want to ask questions that will kind of expand on their chief complaint they come in with. And this helps keep your differentials in mind. Always get vitals. Obviously with COPD, a pulse oximeter is super important because that'll measure the O2 sat. General examination. So how does the patient look? This is another thing I feel like people skip over a lot is like, is the patient toxic or are they not toxic? I mean, especially in the ED, if you're trying to like triage people and figure out like, okay, who needs to be seen first? Like, is this person sick Or is this person okay at this point? Are they stable or are they unstable? So just make sure to take a look at your patients, look at their fingernails, check all over the body. A lot of times you'll find other things that need to be addressed as well that, aren't seen, especially in, say, the older population. If they're in a nursing home and they come in for, say, abdominal pain, when you're doing a full exam, you might come across a gigantic, like this big sacral decubitus ulcer on their back that is causing an infection and causing them to become toxic, right? So we want to take a good look at the patient. Physical exam, heart, lungs, abdomen, all that good stuff. Chest x-ray. So what are the lung processes that are going on? Is there anything going on in the lungs? If he's having shortness of breath and a productive cough, let's check the lungs out. Sputum culture. These things take a while to come back from the lab, but I think they always want to get one just to see, like, is there an infection going on? Is there anything growing down there? EKG, any cardiac problems going on, and then pulmonary function test. So when someone has COPD, it's good to know, like, what is their FEV1 or FVC, right? We want to see, like, has their disease progressed since last time they had PFTs done? What is the severity if this is the first time they're being diagnosed, and so on. And again, the bottom, it's super important to remember, like, you don't want to just go out and order everything and anything. You want to order labs and imaging that will help you rule in or rule out different differentials. So like we did the assessment and plan, we made sure that everything we ordered we were able to kind of put in the assessment and plan to kind of prove or disprove what we thought the patient had. All right, so what are our goals of treatment with COPD? We want to, number one, dilate the airways, right? So we know that they're inflamed, the airways. We know that there's tons of mucus and they're kind of fibrosed up. We want to open those airways up to dilate them, and also to reduce the inflammation to maximize the gas exchange. So here are some different medications that we use. Left column is a type, middle is an example, like a name of one, and then on the right would be the mechanism. So a short-acting beta agonist is going to be albuterol. This is a bronchodilator. Short-acting muscarinic agonist, ipratropium, is also a bronchodilator, and together those are called the duonym, like we talked about before. That's an inhaler. Steroids would be solumedrol, and this is for anti-inflammation. And then oxygen, obviously, we want to start at 2 to 3 liters nasal cannula to reduce the hypoxemia that's going on. So I have a question here. If the patient's hypoxic, why do we give them 2 to 3 liters only? If you remember to our assessment and plan, we said we want to put parameters on the nasal cannula saying, hey, keep that patient between 88 and 92% O2, right? If 95 is normal, why are we keeping them at like a lower level than normal, right? This is because, and let's see if I have a slide on it. Hold on. Nope, I don't. All right. This is because in COPD, so normal people, we breathe because we need oxygen, right? So oxygen is driving our respiratory drive. In a person with COPD, it actually becomes the CO2 that's driving their respiratory drive. So if we take away too much of that CO2 and we give them too much oxygen, it's going to drop their drive to breathe on their own. They're going to go into respiratory distress. So we want to keep them at a slight hypoxic state so that their mind and their body, which is used to tons of CO2, wants to keep breathing, right? I always thought that was a super interesting point, just because it, until you like think about it that way, it's kind of like, why are you doing that? But I think it's very cool. All right. And so here are my references, obviously real patients, and then a bunch of these different papers from UpToDate and stuff. UpToDate is a great resource, so use it if you can. All right, so you're going to fill out the 10-question quiz, the best of your ability. If you score above 80, you'll be emailed certificate of completion, and then also check out your Google folder for additional resources. And of course, I'll be here again Wednesday at 8 p.m. So let me end this, and then I'll check all your. Oh, you guys were answering in the chat. I'm sorry. I feel like that's when I did, Zoom for class. We'd always answer the chat, and teacher would have no idea. So my bad. Stop share.
I just have a quick question.
Of course.
I'm just wondering, where do we find the quiz with the 10 questions?
So it's like a Google form. Did you guys get an email from Motivate MD with it by any chance?
Yeah, it should be with like a doc that we kind of have like a collective bunch of our links and our videos and stuff. Let me go ahead and link it to you right now.
Perfect. Thank you so much.
Thank you, Stephanie. So Madeline, you said GGT is the French word for drip. Wow. I didn't even know that. I was wondering, I was like, what is GGT in here? But that's a good one. I'll never forget. All right. So Stephanie just put that form in the chat. And if you guys are going through, we can totally talk about the questions if anyone needs help. All right, good. Madeline also said 95% or higher. You guys are saying cyanosis. Perfect. Heart attack. All right, you guys are super good. I wish I saw these before. All right, cool. All right. Any questions on anything? We could talk med school, we could talk COPD.
I have a quick question about COPD. Is it common to have like a comorbidity with COPD?
Yeah. So, all right. So this is the thing. When you guys learn in school, you'll learn about like specific diseases on their own. When you see patients, most like 99.9% of the time, they have like a laundry list of different diseases, comorbidities with everything. But especially with COPD, we like to see AFib is common, like we talked about. And I think there is something else that's also common. I mean, you'll see infections a lot, like chest infections, just because they have such inflammation and mucus down there. But yes, it is very common to see other comorbidities.
And then I have one quick follow-up question.
Yeah.
How is COPD affected by like COVID, for instance, because it's a pulmonary infection and it's so invasive and awful? How does that impact the COPD patient?
So from what I have seen is that your COPD patients are going to do worse, right? They're going to do bad because they've already got this inflammation, like you said, in their lungs. And then COVID comes in and kind of wrecks everything up, right? So I think the answer to that question, I mean, I can't give you an exact like physiological just because there's like not that many papers on this stuff right now, but it's not good, right? Because if your lungs are already inflamed and full of mucus and you're barely getting, you know, any oxygen exchange, once you have COPD, you can get pneumonia. I mean, sorry, COVID, then you get pneumonia, then it worsens because now you've got consolidations in your lung and stuff. So I don't think it is a good outlook for, and honestly, if you have any comorbidity and COVID, I think you have a higher chance of like, or a worse mortality rate with it.